I'm Libby Morris, as you've heard. I'm a GP in Edinburgh. That's my main job, but as well as that, for the last few years I've been chairing the project called the Emergency Care Summary. Now, the Emergency Care Summary is the building block of shared records which we've developed in Scotland. And what I'd like to do today is tell you exactly what this is, describe how we implemented it, and then show you some figures and some evaluation. Those of you who live and work in England will be very aware that it's almost exactly the same as the Summary Care Record project, which is being rolled out in England. So there may be some interesting bits and pieces, particularly in the statistics at the end. So, the aims of the Emergency Care Summary, well, it was specifically developed to provide some very basic medical information for any patient who had to get care when their GP practice was closed. All of the information comes from the GP practices. It consists of medication and adverse reaction information. As some people mentioned this morning, just about every single GP surgery in the UK uses electronic health records, particularly for prescribing. So the prescribing is up to date, it's very accurate, and it can be pretty much relied on when it's copied to a central store. The idea was to improve patient care for those patients who needed to get care out of hours. Now, the key principles behind it was mainly to improve the safety of patient care. If someone goes to hospital out of hours or at weekends and they have no idea what medications they're on, then clearly that's got big implications for their safe care. From the very start, it was clinically led. GPs, district nurses, practice nurses all got together and thought about what information would be best to have on the Emergency Care Summary. We started off thinking we would take the entire medical record, and gradually we whittled it down to what was going to be accurate and what was going to be most useful. As I said, the information comes from the GP systems and it's taken twice a day, so it's as up to date as it possibly can be. The patients are all asked for their explicit consent before anyone looks at it. So if a patient goes to A&E, or if a patient phones out of hours, or if a patient phones NHS 24, they're asked for their name, their date of birth, etc. And they're also asked, is it okay if I have your permission to look at this information from your practice? The vast majority of people say yes. Patients can opt in or out at any time. They go along to the GP practice and the GP flicks a switch on the practice system. There's a full audit trail every time anybody looks at one of the records that's recorded with their username, and a full audit trail is not just kept, but it can be looked at by the GP practice at any time, and out-of-hours organisations and health boards have to report on their audits every month. And the approach that we took was an incremental rollout. Now, this is how it works. Any change made by the GP during a consultation or by writing a new prescription in the GP practice gets sent to the system store. The out-of-hours clinician can look at the store on a read-only basis. The practice can then check the audit trail. They can look and see who looked at their patient records. And NHS 24 can access it, A&E, ambulance staff in their cabs, and they just have a read-only view. They can't actually change any of the information. Now, how did we start? Well, right back at the beginning, when we thought, how are we going to do this Emergency Care Summary, we thought we would ask the patients, what did they think about it all? So there was a patient consultation carried out by the Scottish Consumer Council. They held some focus groups with patients and asked them what they thought, what would they like. And the results came out on a very comprehensive report. There's just some key points that I've pulled out here. Patients were generally very, very supportive of having some information available. Their main concerns were related to security and who would be allowed to access it. They generally felt that they wanted to be informed about what was happening, and they also wanted to have the chance to opt out, although in reality very few of them have done that. They still wanted to be given the option. Most of them thought that they should be able to see their emergency care summary, and they can do. They can go along to the GP surgery and ask for a printout. Many of them did recognise the advantages of single patient records, but there were the usual concerns about confidentiality. So there was an incremental rollout in each health board. What we did was identify a clinical champion in every area who made sure that all of the people who were going to be using it, i.e. GP practices, the LMC, the patient groups, made sure that everyone was happy with it before the button was switched on. So each health board did it when they felt they were ready. Most of them did their own advertising, their own awareness raising. Some of them advertised in the local press. Some of them did their own things in addition to the national leaflet rollout. So there was a national communication, but this was backed up by each health board who did what they thought was best in their own area. And one of the key security features, full integration wherever possible. This means that if somebody is working in out of hours, they would access the emergency care system through their own out of hours system. So they would only be able to see the record for that one patient. They wouldn't be able to just browse through all the Gordon Browns in Scotland to see which one they fancied looking at. So, what sort of things can we tell you about the project? Well, it's been going for 4 years now. It's pretty much business as usual. It's widely accepted by patients and by clinicians. So I'm going to show you some graphs of the figures, and also I'll tell you a little bit about some of the evaluations. Almost every GP practice is now connected. NHS 24 is our equivalent of NHS Direct, and all of our out-of-hours calls go directly through them. They're the first point of call. So they do over 60% of the total accesses to the system. The out-of-organisations go through Adastra, which is their clinical system. A&E departments can access through their system. Ambulance the same. Acute receiving units. We started off quite small and have gradually built it up over the last 4 years as more and more people hear about it and more units have requested access. And Northern Ireland have just decided to take it as well. So just some stats. Over 5.3 million records. That's just slightly over the number of the total population. A few people have moved away from Scotland in the last few years, and obviously their records are still there. 0.02% of opt-outs. Almost all of the opt-outs happened in the first wave of publicity, and hardly anyone has opted out since. There have been over 5 million accesses since it was launched in 2006, and it's now reached a steady state of over 190,000 accesses every month, with an increasing rate of use, which I'll show you on this graph here. The red line are the figures for 2008, and the blue line, you can see the increase in 2009. In particular, you can see the increase in April, May, when swine flu broke out. And as we heard this morning from one of the speakers from NHS Direct, there was this huge, massive increase in calls when the swine flu epidemic started. And in fact, the numbers haven't really come down. They've stayed up ever since then. On all the graphs I'm going to show you now, the number of accesses are on the left-hand side. So you can see the months along the bottom and the number of accesses up the left-hand side. This is just the same, but it's broken down into different kinds of users. The turquoise boxes at the bottom are the A&E users. Now, A&E tend not to use it very much. One consultant in Dundee said to me last week he hardly ever looks up ECS for any of his patients, but when he looks it up, it's for something really, really important, and the information is absolutely critical, and he really needs to know which drugs they're on. The purple one, which is going up, is NHS 24, and as I said, they use it most of all. They use it for over 80% of all of their calls. It's just part of their consultation now. The call handler asks for name, date of birth, etc., and the call handler asks for the consent. So when the nurse is then doing the clinical call, they've got the permission and they've got the medication and adverse reactions just as part of their screen, just as part of their consultation.